Thank you. Welcome, everyone, and welcome, Dr. Fausto Rodriguez. It is an honor to present and introduce our speaker today. He is currently Professor of Pathology, Oncology, and Ophthalmology, also Director of the Clinical Neuropathology Service and Co-Director of the Neuropathology Fellowship Program at the Johns Hopkins University School of Medicine. Dr. Rodriguez completed training in anatomic pathology and neuropathology at Mayo Clinic in Rochester, Minnesota, followed by a neuro-oncology research fellowship. He has been a faculty member at Hopkins since 2010. His clinical and research work aims to identify diagnostic, prognostic, and therapeutic biomarkers and targets in tumors of the eye, central, and peripheral nervous system, particularly those that develop in young patients and in the context of inherited tumor syndromes. I will now turn it over to Dr. Rodriguez, who will be discussing some cases focusing on eye pathology today.
All right. Well, it's a pleasure, and thank you for the very kind introduction. And always a pleasure to be here and an honor to present some interesting cases that hopefully have you find educational. So no financial disclosures. These are the specific learning objectives for these studies. So it's going to be a mixture of cases. This is not all encompassing. So it's just cases that we see in our practice, and I found that can have educational points to use. So hopefully that's the case. Let's move right into the cases. This is the first case. It's a 60-year-old woman that had a past medical history, that very complex hypertension, GERD, atrial fibrillation, and died as a complication of those disorders with acute pulmonary hemorrhage and a fistula, as well as aortic dissection discovered on autopsy. There was no clinical history of eye disease. And this is something that we are fortunate here in our service, that we do review autopsy eyes. So the complete autopsy also get the eyes as part of the body. So we get to see a lot of incidentals, and also pathology. Histology is very useful for learning histology well of the eye and for educational purposes. So this is case number one, and hopefully you'll have access to the scan slides. So nothing here, again, there's no clinical history for eye disease, so we will not expect to find much here, but I wanted to put it as an example. There were a couple incidental findings that were of interest, and one of them is, you can see here, and the cornea, when we go by compartments and see if we find anything of interest in these cases. And this one, actually, you can see a lot of actually guttae in the back of the eye here. That is incidental. And this was present bilaterally and in several areas, more even in the middle of the cornea, which is relevant. And then there's also this cute thing here that is also an incidental finding in many of the autopsy cases that we see. And this is a Fuchs adenoma. So this is a high power view, just in case the slide sharing didn't work. And this is a high power magnification, low power of the Fuchs adenoma. So these were a couple incidental findings. They have the same name, so it looks like it's something that you'll see in eye pathology, that there's a lot of eponyms. I'm still learning them, but these are a case that has two incidental eponyms. So Fuchs endothelial corneal dystrophy is actually one of the most common pathologies that we see in eye path in cornea. So it's the most common corneal dystrophy in the US by far. It presents with corneal edema, and usually around the 5th, 6th decade of life. It results from a primary defect in the corneal endothelium. It's relatively easy in most cases to recognize it. It's almost, you see it at low power. The clinical is also very telling. Many of these, with the fancy instruments that ophthalmologists have now, they can pick up remarkably many of these different subtleties in cornea and in intraocular disease. PAS, we use it oftentimes because it highlights very nice the descendant membrane. In equivocal cases, it can help us also to further classify. Fuchs adenoma is a benign tumor, and actually is a age-related growth is usually something that is age-related and incidental. It almost never presents clinically. We almost never seen, I don't think I personally have seen a clinical case that has been coming as a surgical, but we see it in autopsy. And occasionally there are reports of health problems, including complications, iris protrusion, swallowing of the anterior chamber, and even glaucoma, given its location. This is what we tend to see Fuchs dystrophy more often, and we have this dissect or stripping of the posterior part of the cornea. I'm always impressed how this can be accomplished surgically, but they do it very routinely. And you can see here, by the H&E, you can see in the classic cases, these guttural protrusions. You do have some moderate endothelial cell loss. And in very subtle cases, sometimes you have something that is called buried gutta, in which these are not as evident on the H&E, but the PAS highlights it very nicely. So that's another tool that you can have in equivocal cases. Second case, 54-year-old man with visual loss. This was actually an external case, so very little history. And this is case number 2. And this case is more, let me say, so yes, a complete keratoplasty. And something, this is not artifact. You see it for the first time, you say, well, there's maybe some artifact of how it's been staining. But you have these superficial and also in the middle of the stroma, these eosinophilic bright aggregates, which is actually something that's fairly characteristic when you see it. The history also, they can pick up this also very nicely by clinical examination. So it's not usually a diagnostic problem. These are some H&Es, high power. And here, for eye pathology, we do use a lot of special stains still. This is disappearing in many areas of pathology, but sometimes they can be very helpful. For this particular type of dystrophy, Mason trichome is the stain that is very helpful. It became even more, highlights more that fuchsinophilia or redness of tinction that you get with this, which is a granular dystrophy. It's one of the stromal dystrophies. As dystrophy are classified depending on the different compartments of the cornea that you get it. They tend to be very light with PAS, so this is very typical. Almost you see no staining in contrast to the remaining of the cornea. Congo red tends to be also negative. This is a little bit orangophilic, but if you do birefringence, there's no amyloid deposition, which is what expected in the classic cases, in contrast to other stromal dystrophies that we're going to discuss. So this is a granular corneal dystrophy. It presents with visual loss late in life. It's one of the milder forms of the stromal dystrophies, but it may recur in grafts after transplantation. And it's actually an autosomal dominant inherited form associated with this mutation in the transforming growth factor beta. There is a variant that's called Avellino, which features has some features of granular type 1, but also has amyloid deposition, which is a feature of the lattice corneal dystrophies. Many of these dystrophies actually have mutations in the same gene, but there's some genotype and phenotype correlations. These are more severe. You have the lattice corneal dystrophy type 1 and 2, which can result of the confined or local amyloid deposition, or systemic amyloid deposition, again, as a result of accumulation of the abnormal protein product of this mutation. There's a variety of rare forms of stromal dystrophy. One of them is called macular corneal dystrophy. That's most aggressive. It's autosomal recessive, and it's more results in polysaccharide deposition. So it's almost can be interpreted as a localized mucopolysaccharidosis. This particular patient, actually, this is the graft. So some of these dystrophies, which is remarkable, can recur in the graft. And when they do, they tend to be, the aggregates in these granular dystrophies tend to be more superficial. So this is actually a graft in which the patient, in severe cases, they get transplanted, corneal transplantation, and they can recurrence of it, unfortunately. Okay, the next case is a 71-year-old woman with corneal edema. Again, for some of these cases, we see we have limited history. Number 3 here. So if you see, this is actually something that may be subtle. You can tell that maybe there's something going on here. It is actually is probably a graft. We have very little history given the scarring and all that. And if you see around, you say, well, this is probably not normal. But you start seeing here some subtle areas of pallor and almost what you can say even a little bit of almost crystalline type of suggestion. This is very, you see, it's somewhat subtle. No inflammation. That is something that is very key. You have a bit of maybe minimal at most, but it's mostly a little bit of scarring. And this is what you can see in those areas of pallor. You see, if you do, they're a little bit refractile. If you start turning the condenser, and you start seeing some subtleties here. This is the PAS, which even highlights it a little bit more. And again, they have almost this crystalline quality almost. So you have a broad differential here. There's a variety of systemic diseases. You can have immunoglobulin-derived crystals and other things in rare pathologies. But in this case, what was helpful was the gram stain. So this is two different forms of gram stains. It's good to have both because you want to confirm it to avoid artifacts. And you have a bunch of gram positives here confirmed by the Gram-Weigert and the Brown and Hobbs. And this is actually a relatively rare disorder. It's called infectious pseudocrystalline keratopathy, which is an indolent corneal infection caused by a virulent streptococcal stains. You have these intrastromal opacities in the absence of inflammation. So it's an infection process, but you don't see the inflammation to point you in that direction. Complications of corneal surgery, grafts, and corticosteroids. So this tends to be something that happen when you have a localized immunosuppression in the area. And aggressive antibiotic therapy is required, and sometimes in very severe cases, like here, you have to do a PKA. I wanted to put this as an example because you do have a variety of infectious keratitis, and in IPATH, there are many things that you actually see after the fact, right? So if you have a Fuchs dystrophy and you miss it, you don't feel, you still can sleep at night because, you know, the treatment has already been done. It's almost certain that what the diagnosis is. But these infection ones are the ones that you really don't want to miss. These are things that are very critical. And you have a variety of pathogens that can involve the cornea. And you can see many times you may have some. I wanted to show that case, even though it's a rare example, to highlight that when you see something very funny, don't be shy about throwing a bunch of microorganism stains there, because special stains, because that's when you're going to make a difference, really. Some of these patients can be, cured, and there's a variety of things. Bacteria, this is one example of something that is bacteria. It's not an active purulent keratitis, which you will see more commonly, or ulcer, but it's a very subtle infection that is good to pick up. You have mycobacterial infections. Occasionally, we are doing AFB stains less and less in general pathology, but we have picked up incidentally that we have picked up double type of infections. So it's good to have panel of stains. I will be very liberal in ordering these. When you see something in a cornea that is very funny, you have viral infections. Many times you see the after effects, more often the scarring that results from that. Fungal infections, we've seen a variety of them. And the one that you really don't want to miss, and that is also very subtle, is the acanthamoeba, which is an infection that results from associated with contact lens use. This is extremely subtle when you see it, and it's also, can be a problem with litigation, actually, because it's very easy to miss. You barely see it by H&E, but when you do the stains and the grams and the GMS, they pop out. So you really, once you think about it, Many times you have the suspicion from the clinical side. Sometimes you have scrapings. Sometimes you don't have a whole pKa. So this can be solved, but these are some things to really keep in mind. All right, moving now more into tumors. The next case is a 6-month-old boy with an intraocular mass. And this is a slide, and I'm glad that the whole thing came out scanned very nicely. Not subtle, very necrotic tumor. I think we can all agree that this is something malignant, right? Young patient, intraocular tumor associated with the retina. I think the diagnosis probably is not in question, even from the preclinical part or from the pathology part. This is a retinoblastoma, right? It's a round blue cell tumor involving the intraocular compartment. The differential is very limited here. But the morphology here, I wanted to highlight, point out to something that if you go on high power, it doesn't look like your typical round blue cell tumor. The cells are actually larger and have these this cohesive type of appearance. A lot of mitotic figures, a lot of apoptotic figures, and prominent nucleoli. So this is something that is something that has been highlighted by publications in recent years and by our colleagues, particularly Dr. Eagle, who see a lot of these in the Wills Eye Institute and other colleagues in IPATH. So this is again some H&Es as a backup in case so this is a retinoblastoma, and we know retinoblastoma is one of the most common, if not the most common, intraocular neoplasm in children. We don't see it as much in the United States at the moment, but it's still seen in other parts of the world, particularly in advanced stages. It usually presents as calcified mass. The clinical history is many times very classic, usually a subject of board testing. You do have a leukocoria or a white pupil, or you have loss of the retinal reflex on photographs. That's another way that sometimes these get picked up by a astute parent. This is usually one of the models really for cancer biology of the Knudsen hypothesis or developing as a result of inactivation of the RB1 tumor suppressor, and which can happen by two different mechanisms. You can do the inherited part, in which you inherit one copy of a defective allele, and you lose it somatically, and you get tumor. Many times, since you have a hit already in every cell of your body, you get this early on. Some of these can be actually large lesions or point mutations. And you have tumor at a specific age, and you can have multifocality and bilateral involvement. So these are patients that are very important to catch up early. And then you have some that occur in older patients in which you happen to have somatic inactivation of both copies. So it's a very historically important model of carcinogenesis in general. So now this case is remarkable because this is something that has been highlighted. The morphology is a little bit different. You have these macronucleoli, and these tumors actually, there's this subset of tumors that don't have RB1 loss. And there's some heterogeneity about other alterations that are known to be drivers, but this one actually is a known one, which is MYCN amplification. These are retinoblastomas that are associated with MYCN amplification. And as in other tumors in the body, whether it's medulloblastomas, neuroblastomas, now we're trying to see similar morphology even in ependymomas of the spinal cord. You have this amplified MYC that gives a slightly different morphology, and there is some enthusiasm in studying these. The experience is very little with this because this is a really small proportion. The majority of retinoblastomas have actually, in fact, loss of RB1. So these tend to occur in younger, it has a younger age of onset, this particular subgroup, and seems to be associated with aggressive histology. The question is whether it's more aggressive clinically. And I think, again, there are some limitations in those analyses based on the limited number of cases where this happens, but something just from the molecular biology standpoint point of view that is interesting to know. Moving on into case 5, this is a 63-year-old man that started experiencing tearing, swelling, and pain of the left eye, progressive eye swelling over several months, and left eye proptosis. This is the scan, and you can see there are actually some enhancing nodules that are involving the left orbit. And this is one of the biopsies from the orbit. Right away, you can tell, well, this is not normal, right? Sometimes you have things that are, you have a little bit of inflammation. There are a lot of inflammatory disorders that you're gonna get in iPath specimens, chronic conjunctivitis, etc. This one seems to be a little bit too much, right? I mean, it's just back-to-back wall of small lymphocytes. And sometimes you can see this in the conjunctiva biopsies. And this, you have really quite a few nodules, which are very worrisome for something malignant. This is it. And you see as wall-to-wall CD20 positive cells. Also has quite a bit of CD43 that is an excess of the T cells. So you have an aberrant expression of CD43, which is another clue for this particular lymphoma subtype. The flow cytometry was very helpful here. It really is able to show the monoclonal expression of kappa light chains, which is more tricky to pick up with immunostains and sections. And sometimes you may have very tiny biopsies on these cases from if the involvement is limited from the conjunctiva. So this helps you confirm that it is really indeed a neoplastic. And this is an extranodal marginal. Findings are consistent with this type of diagnosis, extranodal marginal B-cell lymphoma. It's important to highlight this is a similar situation where you see in the brain. Actually, you do have the ones that occur in the ocular annexa, orbit, conjunctiva tend to be more of this marginal zone. The same thing as you see with some primary CNS lymphomas that occur intracranially that can present with imaging features resembling meningioma. This is in contrast of the intraocular lymphomas, which are usually the primary ones are of the large B-cell lymphoma phenotype, and again are related to the primary CNS lymphomas, which are also primarily B-cell lymphoma. So the message here is how to approach it. If you have something that is considered to be lymphoma, externally, extraaxial in the brain, or with no secondary, no primary history elsewhere in the body, or in the ocular annexa, it is a good habit to try to save some for flow cytometry. But for the intraocular ones, again, and also for the intraparenchymal ones, that's something I really teach the trainees. If you have very limited tissue, flow cytometry is not that necessary or useful there. So you can sort those out better with stains. These ones have a very indolent course, like extranodal marginal zone lymphomas and many other different organ sites. Okay, case number 6. Okay. And this is actually I have to. So it was a 54-year-old man with a lesion of the right eyelid. So painful and itchy, and appearance consistent with chalazion. I don't know how much in the audience, those who do iPath, how many of eyelid lesions you see. Sometimes these tend to go to their path. In our service, we see a lot of these because they come first to the ophthalmic pathology service. And we do actually rely a lot on our colleagues in their path for this diagnosis, but something it's good at least to have in mind. But this is a very classic presentation for this type of lesion, 54-year-old man that had something that was called consistent with a chalazion. Again, a chalazion is a common lesion also that we see from eyelids in in ophthalmic path. This was the biopsy. Not subtle to identify this as something malignant, right? You have a lot of mitosis. Necrosis is sometimes natural to think about this as maybe just a squamous cell carcinoma or something like that. But you start here seeing the cytology. The cells have a lot of bubbly cytoplasm. So this is almost location-specific tumor that is important to note. And you can see here that's a nice separation from the involved skin of the eyelid. So here's a high power. And this is a sebaceous carcinoma, which usually affects elderly patients. You almost never see it before the age of 50. Has a predilection for the eyelids. It's another one that tends to have a location specific. So it's in that respect, highly relevant for eye path. The presentation as a chelation is very, very typical. So it's said that if you have first from the pathology side, when you receive chelations, this is something that you always should, particularly in an older patient, you really want to inspect very carefully because the diagnosis here that I show you is a good case, but it can be extremely subtle. So it's important to really look at these very carefully from the pathology side and from the clinical side. When you have a chelation in particular that recurs, this is something that they also have to start thinking because it might be the initial presentation of this disease. And the earlier you catch it, the patients that really affects can affect survival. The diagnostic morphology features are present, but when you have minimal involvement, you can have pyezoid spread, individual cells going into the skin. That can be very challenging to diagnose. And this is actually something to think about. You see here, this is a case a little bit more subtle. You have this bubbliness, but this is really, you start struggling sometimes with some of these. Maybe this is subtle involvement here, but again, not overly bad. And the same here, you have this is more involving conjunctival, so spreading inside. So this is because it's one of the areas in ophthalmic path that you say, well, you know, when you are tired of all these margin type of biopsies that you may see in general path, this is an area where you still get them. They do a lot. This you can get a lot of margins on these cases, and they are very challenging to review and may take you quite a bit of time if you have to deal with them. Okay, next case, 68-year-old woman with a mass in the right nasal bulbar conjunctiva extending to the caruncle, from the caruncle to the limbus, measuring about 12 millimeters in maximum dimension. And this is it. And you know, this is actually conjunctiva, believe it or not. The reason I wanted to show you this case is that this is not something we see that often anymore. So big bulge in the conjunctiva of pigmented cells. You see, it's very difficult for this to remain subtle. So these usually are taken out, but at a much earlier stage. But this was one where that didn't happen. It's sometimes good for these tumors to see the interface with the conjunctiva, some inflammation, but not a subtle case. Here, low power and high power, macronucleoli, pigment. And this is actually a melanoma involving the conjunctiva. This one had enough material to send for NGS. Sometimes with these small pieces, it's tricky to do, but this one actually had a BRAF V600K mutation. It's another activated mutation, a little bit less frequent than the conventional BRAF V600E that we tend to see at a high VAF. So very clear here by next generation sequencing. So conjunctival melanoma is relatively rare compared to uveal melanoma. In iPath, we tend to think more about uveal melanoma. It has a precursor, which is this primary acquired melanosis. That is something I don't have the time to go with you, and it's something that a little bit confusing the terminology that is used. It's sometimes change and difficult to evaluate. So many of these is good to, if you have good colleagues to share with, either colleagues in ophthalmic path or in IPAth and derm path. This is important because this grading atypia and these are very tricky, and they don't always correspond to the ones that you see to the criteria that you see in derm path. One thing is lymphatic spread can be seen in advanced cases. This is in contrast to uveal melanoma, where you see hematogenous metastases are more typical of the clinical course, particularly with involvement of the liver. So these has a lot of, you have to think about these have a lot of things in common, more so with cutaneous melanoma, seems to be associated with UV light as well, and more so has more things in common with cutaneous melanoma than uveal melanoma. That's the main point to have in these cases. Excentuation sometimes is performed in cases where you have a lot of recurrence and orbital involvement. And in fact, that happened with this patient, unfortunately. Alterations in the MAP kinase pathway components are typical, be RAF, RAS, etc. This is in contrast again to uveal melanoma, where you have more similarities with melanocytic tumors of the CNS, and you have higher frequency of GNAC and GNA11 mutations, which can be helpful in diagnostic in specific cases. On follow-up, actually, the patient was treated with sometimes they have these radioactive plaques that they put in cryo, but there was recurrence and there was orbital exenteration 8 months later. So the right orbit has, after this exenteration, shows no evidence of recurrence at 2 years. This was the left eye, which has been monitored very closely because they had found some melanocytosis that has been stable, a little bit of alterations in pigment there in the choroid. But the patient is actually stable with no evidence of recurrence. Okay, in case 8 is a very interesting finding at autopsy that we saw very recently. 72-year-old man with a complicated mesenchymal history, particularly sarcoidosis, had sudden loss of the vision in the right eye, and blindness, was presumptively treated for what happened to be the right diagnosis in this case, but developed progressive decline, weakness, fatigue, and mental fogginess for other health problems. But this was complicated by hypoxemia, shock, metabolic acidosis, and the patient died. In the autopsy revealed organizing pneumonia and actual hemophagocytic histiocytosis. So very complex clinical course. And this is again another eyes in an autopsy. You can see here some lens remnants from probably cataractus surgery at some point. A lot of severe cataractus changes. Again, these are specimens that are very useful to study to learn histology and all of the eye and anatomy of the eye. But if you go high power, here is, hopefully you start seeing these. Some changes here, inclusions, some degenerative changes. And even more here. Unfortunately, the retina detaches quite a bit when these cases are sectioned, but something that is not normal at all. Again, and you do have real viral inclusions here. Some high power views, the areas that I was showing you. There was some optic nerve atrophy with increased trabecula and a shrinkage of the size. And this is immunostain for CMV. And the patient actually was diagnosed in life with CMV, treated with ganciclovir, but didn't have, they didn't have, unfortunately, much success, and the patient had other complications, as I mentioned. So case of CMV retinitis, we don't see this too much anymore, right? This was used to be one of the complications of advanced AIDS, that when the epidemic, of advanced AIDS, those patients were coming more and more to attention, to autopsy and clinical care. But this is one in which develop in another context, in the context actually of sarcoidosis. And you can see this can be a very severe complication of immunosuppression. These are some of the references of some of the that I use for some of the cases that may be useful. And I think we're going to have time for some poll questions, I assume.
Yes, would you like to go? Thank you so much, Fausto. These were really, really illustrative and really nice cases.
Thank you.
Would you like to go ahead and launch the poll questions so that we can address case by case if there are questions? I can take care of that.
If you don't mind, yeah.
So,
Yep.
Oh, there we go. We already did that. So question 1 is in progress. And we can see people are already responding very quickly. You can see this, Fausto, too, right?
Yep.
Right, we have good amount of responses. There's still 30 seconds left, but it seems like we have a pretty solid consensus about the answer for this case. So do you know if you were to I guess do methylome analysis on these, do these cluster with medulloblastomas that have MYCN amplification?
That's an excellent question. I'm not sure if it has been done. I'm sure that people probably are looking into it. I know it has been done for medulloepithelioma, right? Where it's another tumor that you have, and I can remember. I think they don't cluster very well with some of the they are a little bit different from the intracranial medulloepitheliomas, which they have a slightly different pathogenesis anyway molecularly. So that has been done, but for these ones, I'm not sure. There's a spectrum of embryonal tumors that have these MYC amplicon, and it looks like it leads to this morphology. And even in this now group that is known, this spinal cord ependymomas that are more aggressive, it's a new category. You do have sometimes similar morphologic features, even though they are not really embryonal tumors, right? So, but I don't know if that would be an excellent idea. Something to do is to see if they cluster by methylation with that. But these are relatively rare, of course. But certainly something probably worthwhile. Maybe somebody's already doing it, but I haven't heard anything about it.
Okay, great. So Bonnie, I guess we could launch the next question.
Okay. So MYCN amplification was the right, and we call it that's as the terminology has been applied anaplastic to the medulloblastomas that have MYC amplification. More often in medulloblastomas is CMYC that gets amplified, but you also have some with MYCN.
All right, this one is not as robust a consensus as the prior one. So,
and in fact, maybe because there's some truth, I think, to some of the other to some of the questions here. So I will say that we stopped the polling, right?
Yes.
Okay, so mesenteric is what historically we use for these because it really highlights the red. I mean, that is what is very typical. So that's correct. That's what my intention was. but we can argue that other stains are important here. Congo red is important because it allows you to separate the other more aggressive type of stromal dystrophies that have Congo red in addition sometimes to Mason trichrome. So the Congo red may be helpful, and I guess I will do both. In these cases, you will do you do both, and it's important also for the evaluation. So I will say that here there's no right. The most common one that for the positive side is Mason trichrome, but Congo red is important to exclude the others. Luxofil blue can be sometimes positive in some of these dystrophies, but we don't use it as much, you know, for corneal staining. And I guess gram stain will not be a bad idea sometimes to stain if you are concerned that this could be something infectious. And I show a case of pseudocrystalline keratopathy. So that is that would not be, there will be nothing bad. It's always good to have infection in the back of your mind, because that's what's something that you can really have an impact on the patient and on the graft. You know, it's a nightmare when these infections just spread for the graft, you know, after they go through all that, and sometimes even intraocularly. So that's always having infection is a good idea. So I think that maybe there's some truth here for the mind thought process here, that how this question was approached by the audience.
Great, thank you. All right, okay, we can go to question 3. While people are answering, I just mentioned there was a comment received that from Dr. Seidman that the term Avellino dystrophy is no longer in use. I don't know if you want to comment on that.
That's fine. I mean, it's not my area of expertise. So I mean, I go by sometimes what I historically so. Thank you for the clarification. I'm sure you know, I don't follow the literature very closely, to be honest, for this, but thank you for that's an excellent clarification. It's of historical importance, I know, but I know that things are now that these are being clarified more by genetics and other things. I think there is there's some changes in terminology.
Right. 10 seconds left for the question on lymphoma.
Okay. So you can see, essentially, you can see a lot of lymphomas. A lot of things can present in the orbit, but the most common lymphoma of the ocular anexa, this includes the orbit, lacrimal gland, conjunctiva, is extranodal marginal zone lymphoma. Large B-cell lymphoma, you can see it on occasion, but this is the most common type of intraocular lymphoma. So those are also some contrast. Okay, we have seen on occasion anaplastic large T-cell lymphoma, but that will be very rare.
All right, great. Question 4. We have very speedy participants.
Yeah, I'm very happy that paying attention.
Right, 100%.
Okay, wow. Okay, so yeah, this is very typical chelation, either from the pathology side. I said you have to pay attention to those when you examine them. You know, the presentation is so classic that sometimes it's one of those specimens. If you have a very active eye plastics group, you see these all the time, and it's very easy to brush, to go fast through them. But these are the ones that you don't want to miss, particularly older patients. Recurrent chelation is also something that is a key thing that you have to keep in mind. Those are the ones that are more dangerous, and that also goes from the clinical side.
Okay, we have one more question then. All right, so hall is closed.
Okay. So, yep. So BRAF is the right answer. I mean, in BRAF and other MAP kinase pathway type of alteration. So the idea here is that this is closer, the conjunctival melanoma is closer to cutaneous melanoma. While GNAC, you see it more often in the uveal melanomas and intracranial melanocytic, primary melanocytic proliferation. So that's a key distinction from the biologic standpoint. RB1, I'm not aware. I mean, maybe you can see it in many different malignancies. Could be seen. I'm not sure if you see it as a secondary hit, so I cannot definitely say that this is completely wrong. But the driver really are as in cutaneous melanoma, BRAF is a frequent driver that you will see in these tumors.
All right, so in reference to that, we have a question in the chat from Dr. Daoud. Do you do molecular analysis for all BRAF mutations for ocular melanomas in place of the screening V600E immunohistochemistry?
That's an excellent question. I wanted to share this case again because to us was remarkable seeing this like a big chunk in the conjunctiva. I don't think there are very few people who leave this, growing there. So, more often what you see more by biopsy, more than melanoma, we see a lot of these PAMs, or primary acquired melanosis, and these patients get very aggressively followed. They get excised and they do margins and they get seen very frequently. So melanoma, many times you don't end up seeing it very often. And when you do, maybe it's more in an early biopsy. So it's very difficult to find. You see the spectrum of mutations is a bit more variable, and you're gonna see probably some publications coming out in MAP kinase, other MAP kinase pathway components. So it's a good way to screen it, particularly for small biopsies, and it may have everything. You have it. For the example that I showed you, for example, it was not a V600E, it was a V600K, and you have NRAS mutations and other things. So it will not capture all of them. So if you're able to do NGS, it's worthwhile doing it. But most of the time, maybe with the immunostain, maybe all you can do actually. So.
All right. Thank you so much. I'm not seeing any more questions, but I'll just remind everybody that the Q&A is open for questions that can be submitted through the chat, or if you are willing, you can also unmute yourself and ask your question directly. And if not, maybe it means that we've learned all there is to know about.
Oh, I doubt it. I have a lot to learn as we can in some of the comments. So
Fausto, can I ask a question?
Yes. Great to hear you.
This is Tony from Florida. How are you doing?
Can't miss that voice.
Well, that was a great talk, and I enjoyed the cases very much. Very
Thank you.
Helpful for those of us who struggle through eye pathology. I just wondered, is there any special stains or special studies you can do for sebaceous carcinoma? And I'm sorry if I missed it.
No, I didn't cover that. And certainly it's very tricky. Their spectrum, my feeling is, when you are, the one that is seen most as this adipophyllin stain. So the apophyllin stain has been, Dr. Tatiana Millman has, worked a lot with it and has a lot of experience. And at one point we were, helped us, even I think incorporate in our validation as well. The situation is, it works well. The problem is that you see it in the cases that are less problematic, right? So the ones that have a lot of vacuoles, that you see it by H&E, and you say, well, this is sebaceous carcinoma by H&E. Those are the ones that tend to be more positive. The more poorly differentiated ones, when you start thinking, could this be just another head and neck type of malignancy? And those is more subtle. And then when you start seeing just a few random vacuoles, you doubt yourself whether you can use that to really clinch the diagnosis. So, but it's among the stains, is one of the most useful ones. And then there are different keratins that are, seen a bit more very before, and other keratins that can be helpful, but there's overlap, there's quite a bit of overlap with squamous cell carcinoma in my experience for these. So, which is one of the main things that you have. One thing is you want also to exclude melanoma, and that is a little bit more helpful. Keratins, EMA is frequently positive as well, and do melanocytic markers. I will try to exclude melanoma for sure. Adipofilling is one that, as close to you can say for a specific. The mismatch repair ones are usually not that helpful because you don't see it. You don't see very often. Most of these are the sporadic ones that are not associated with mismatch repair deficiency. So,
Dr. Abul-Kader asks about how about androgen receptor for sebaceous carcinoma?
That's an excellent question. I can't remember what our experience there. I mean, I know that there has been done. Again, most of the time I tell you, we use it more. The morphology is really for us the most helpful, and adipofilling. Those are the things to me that have been more helpful in my experience. But I'm sure that there are other stains that can help in specific contexts, including androgen receptor. Yeah.
Thank you. Dr. Oviedo wants to know which of these lesions that we've discussed today are important for medical students to know.
Oh, I will say all, right? I mean, I think for medical students in general, I wanted to share that case of CMV retinitis because it has a very important historical significance. You don't see it as much from the path side, right? But I think from the clinical side, it's a very important sort of blindness in the immunosuppressed population. You're seeing it less and less now in the AIDS epidemic since it's being more effectively treated. But that one actually was identified clinically, and there can be some impact to treatment. So from treatment purposes, that's something to have in mind. I tell you, a lot of the corneal things that we see, I mean, that it's a big part of ophthalmic pathology. It's barely covered in medical school. So I think it's good to know that there you have a spectrum of disorders that affect the cornea that are seen, because I tell you, I didn't know anything about these when I started doing, even through my pathology residency, until I started having to sign them out actually that these exist, and there's a classification, and some of them have very interesting genetics, and for those who eventually will have an interest in going into ophthalmology, that I think these are also very good to study. So I will say those are it's good to pay attention to that as a medical student, particularly if you have some interest in pathology at some point in ophthalmology to know.
Great. Someone also adds that I guess probably from experience they say that androgen receptor and p53 are very good for sebaceous carcinoma. This is Dr. Harris. Right,
and I know that those are we do it sometimes.
Does sebaceous carcinoma have a different molecular background than other squamous cells that can arise in the vicinity?
Yeah, there's let me see, the molecular they are different, but I think this is something that is still being our understanding is still evolving. I think there's not as many studies on it, unfortunately. Again, we can comb the literature and find some studies here and there, but p53, that's what came from the audience. That's accurate. You see it, but again, I didn't say. I mean, this is used a lot, but you can see it in I see it in squamous cell carcinomas many times. So those are things that in practice many times end up being difficult. To give you if you want to find something that tells you, yes, I'm seeing these, I'm thinking about both, but this is really definitely sebaceous carcinoma because it's positive for p53 or even adipofilling, to be honest, so which is the one that I tend to rely on the most.
Okay. We have Dr. Plowey raised his hand, wants to perhaps ask a question.
I just wanted to see if I could get when I was practicing IPATH, I had this probably irrational over paranoia about missing a Canthamoeba. Do you have any pearls of wisdom on the diagnosis? What's the most subtle case you've ever seen? have you ever leveled into blocks to better see organisms? And in recent years, has ribosomal RNA sequencing or other molecular diagnostics been of help?
Yes, no, that's an excellent point, because I share that paranoia as well. The situation is that, you know, we have a busy busy corneal service, so, you know, you sometimes have a stack of 10 corneas, and, you know, you think about it in every corner, but, you know, the question is how long you do. One thing is, you know, there is occasionally, if this from the clinical side, they suspect, many times they suspected. I mean, we have really, fortunately, very bright ophthalmologists here, and sometimes some of these specimens come from by scraping first. And they really are concerned about it. So we really are looking very carefully for those. Levels will be helpful in sort of cases. If there's any clinical suspicion, or there's something that suggests an infection of any kind, and you have I think if there's an infection subjective whatsoever from the clinical side, and you have something that almost look normal, that's one that you also, you know, have to really think about. So levels is fine. The stains highlight them very nicely. The GMS, in my experience, helps. So, you know, I do GMS and PAs at the same time. They do highlight it. So if you looking at that, doing levels, we do levels more often, you know, here than in IPATH than in, for example, in the neuropath scenario. So those are all appropriate ones. But many times, I tell you, most of the time they are clinically suspecting it for one reason or the other. So, so that has been very helpful. Regarding new techniques, there's some sequencing approaches now. This pan microbe sequencing that is happening. My colleague Dr. Eberhard has participated in a study of that. I can't remember if they had a Cantamilla, but I mean, it should be able to, has a lot of potential to pick up those and other microbes that many times we don't pick up by special stains, or when the special stains, you really have to dismiss them because you're, you know, you have something that looks equivocal, you know, so.
Thanks.
Oh, you're welcome.
Okay, it's 11:59. Looks like we're all out of questions.
All right. If there are questions that arise later, you know, people are feel to email me. I'm available anytime to chat or answer anything. And again, this is not all encompassing. These are just things that we see in our practice, and I wanted to share with you all and hopefully generate discussions. And I'm really grateful to all the comments.
Yeah, thank you. I think Bonnie might have some comments to finish the session.
Yep. Thank you again, everyone, for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation, which will be entered into the chat box momentarily. Completion helps ensure accurate reporting to the accreditation board. It may not display as a link, so please copy and paste it into your web browser if needed. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Rodriguez for an excellent presentation, and this concludes our session for today.
All right. Thank you very much, guys. See you in the next one.
Thank you very much.